Hello everyone, welcome to the cholesterol lecture. We'll be going over cholesterol similar to what we did last fall, so some of this will be review and it'll be several of the same medications we already talked about, but going into a little bit more depth, talking about the guidelines a little bit more, bringing up familial hypercholesterolemia, and just generally digging into some of the other medications outside of statins a little bit more. Even though they aren't used a lot, I figure it's worth talking about because they do come up from time to time and people do take them. Some of them are over the counter too. So with that being said, let's start with just a quick review of the disease. So atherosclerosis is a buildup of plaque in the arterial wall. As you guys probably know already from pathophys and whatnot, this is a major cause of heart attack and myocardial and various types of acute coronary syndrome. So whether it's a STEMI or an NSTEMI or unstable angina, it's all caused due to poor circulation or obstructed circulation. And this is usually what the issue is. So what happens is you end up with plaque buildup in the arterial wall. It develops over time, and then you get more and more restricted blood flow. And ultimately, these plaques can rupture through if the wall gets thin enough, and that can lead to a clotting cascade system. So you get platelet aggregation, you get clotting factors that come as well, and ultimately that completely occludes the artery, and that's what causes an infarction. So things that we can do to prevent this, there's lots of correlations with things like diet, genetics, smoking, and diabetes. Obviously, some of these we can't help, like genetics. And we'll talk about familial hypercholesterolemia a little bit, but that's something that is a little bit more difficult, whereas there's more controllable risk factors such as smoking and diabetes. It is the leading cause of death in most Western countries, so in the United States and Europe, and many patients will be treated for high cholesterol. So it's just a really common treatment. So I think it's one of the one lectures where it's probably good to talk about both. And it's kind of an endocrine thing. Well, it is. So that's where it's slotted within Clin Med. That's why I bring it up here, but it's much more cardiovascular thing, which is why I brought it up earlier in the fall too, just to give us a little sense of where we're going to go with this. So it's really going to be very similar, but again, we're just going to dive into the details a little bit more. I really just want you to know the basics behind cholesterol for my tests, so understanding LDL treatments, high-density lipoproteins. Remember, low-density lipoprotein and high-density lipoprotein are just two protein transporters and essentially are bringing cholesterol to different places. So LDL is going to transport cholesterol to cells, and HDL is going to scavenge cholesterol and bring them back to the liver. So the way that we measure cholesterol, when you look at LDL, the idea is if you have a really high LDL, it means your body is upregulating the production of this protein and transferring it all over the body. Whereas if you have a high amount of HDL or high density lipoprotein, it means that your body is scavenging a lot of cholesterol and bringing it back to the liver or using it for other things. And remember, cholesterol is used for a lot of different structures in the body. So it's part of our cell wall, or cell membrane, I should say. And it's also part of the initiation as far as all of our hormones go. So sex hormones, cortisol, those are all initiated via cholesterol. So cholesterol is a really important molecule. It's just if you have too much of it, it gets distributed in odd places in the body. And that's what can lead to some of these negative outcomes. Triglycerides are fat made by the body, also a useful source of energy. And of course, you can get too high of triglycerides if your body is storing more than it needs. Usually goes hand in hand with high LDL and diabetes as well. Now, we get into the more advanced parts of cholesterol, which isn't super important for the point of this class. And hopefully you touch on this in pathophys too. I'm just going to go over it really briefly. But you have a couple different parts of cholesterol that make up the whole picture. So I think it's somewhat important just to talk about it. You have chylomicrons and very low density lipoproteins, or VLDLs, and these deliver energy-rich triacylglycerols to cells in the body. And so what happens is you get a compound that can be broken down into other fatty acids or stored as adipose tissue. LDL, we talked about delivering cholesterol to the body. So how does VLDL fit into this? Well, VLDL particles get stripped of their tag, which ultimately increases their density, and the particles basically are remodeled into the liver into LDL. So as they're getting broken down and removed of this tag product, you get the formation of LDL, essentially. LDL binds to an LDL receptor, which releases cholesterol molecules and allows them to be moved to different areas of the body. HDL involvement is reverse cholesterol transport, so excessive cholesterol is eliminated in the body from the liver, secreted in bile, and converted into bile salts. An HDL precursor synthesized by the liver, sent out to collect cholesterol, and then returns it to HDL. So again, kind of what we just talked about, but just a little bit more in depth here. If you like simple drawings with dotted lines and colors, this slide is for you. This shows a little bit more about the whole process, but again, it's really just what we've talked about. So again, the point, and I'm not going to test you on a lot of this, it's just for background information, but we talk about LDL as bad cholesterol and HDL as good cholesterol. I just like to point out that we aren't actually measuring cholesterol specifically. You're measuring the liver's reaction to cholesterol and what it's doing as far as trying to either metabolize the cholesterol or to distribute it to other parts of the body. LDL goals are not really a thing anymore, but that's not entirely true. But this is what they used to be. So in case you're wondering, like, what's a normal cholesterol? That's the only reason I leave this on here. These aren't really goals anymore. So I'd probably just say LDL levels, maybe. I don't know. You can kind of rename it how you want to think about it, but they aren't goals. But if you did do a cholesterol level on a healthy person, you should probably be under 100 for most people. And there is periodic screening for this as well through physicals and primary care. So if your LDL comes back above 190, that's pretty easy to do from a treatment standpoint. It's these middle numbers now. We used to treat them pretty standard. So like if you were above 100 but below 130, you'd probably be started on statin therapy. Well, the new guidelines don't really support that anymore. So the question is, what exactly do you do for those people? It's a great question. So we look at other things like risk factors and look at the whole picture. So if you do and I'll show you the calculator, we'll go into a little bit more depth on that. But if you calculate now, it takes these things into consideration. But if you're really high in LDL, we don't really care what your risk factor is. We're going to treat you with some lipid-lowering therapies right off the bat. And if you're under 100, you don't need that. So anything in between, though, it's considered you're close. Maybe if you're like 120, if you're 160, you're getting pretty high. So some of that might be let's have a conversation with our patient about what they feel comfortable with. Your lipids are looking a little high. You've tried some diet and exercise. You've tried some lifestyle modifications, still high. What do you think about statin therapy? Are you interested in it? Are you opposed to it? And have those conversations. So that's an appropriate strategy as well. Okay. I remember these old ATP3 guidelines. I still like putting them on here just because they show you where we were and what we used to do. And these were such standard for so many years with statin therapy that I think that a lot of providers might still have them ingrained into their head. Not that they're ignoring the new guidelines or anything like that, but they might just think, well, this is what I used to do and it seemed to work. And I kind of like having a more stratified approach this way. And it's just that there isn't really evidence to support all these different tweaking. So some of the big things that they removed that were proven basically to have not any impact were this optional target of below 70 for LDL. So people who are really high risk, so who had a 10-year risk score greater than 20% or had CHD or CHD risk equivalents. And you can see some of the definitions down here of what that would be. And that was this aggressive target that it was really hard to meet. People were on high dose statins and they were taking niacin and fibrates and all kinds of other things just to maximize their lipid lowering potential. And we were really just focusing on that number and showed that it didn't really matter as long as they were on a statin therapy. And in some cases, high dose, high intensity statin therapy was appropriate. But all the ancillary stuff to really focus on that number just wasn't really important. It was really the markers, the biomarkers of inflammation that statins were affecting and things like that seemed to be more the impact versus just simply lowering the LDL. Certainly lowering the LDL has something to do with it, but lowering it aggressively just doesn't seem to make a whole lot of sense, and there's no real guidelines that support targeting a super aggressive goal even if you are really high risk. And then they had these other ones, moderately high risk, moderate risk, low risk, depending on what risk factors you had. And then they would, and again, the risk factors here, you can see here. And now, if you think about the way we approach it now, we do the 10-year risk score and kind of base our treatment off of that. And it's much more looking at all the risk factors together and using that calculator to figure out where you fall. And that's really the important thing that the guidelines have shifted towards, and shifted away from let's just look at LDL and let's target these goals. And let's kind of look at the risk factors as secondary. Risk factors have come to more of the forefront, I think, with the new strategy. All right, so anyway, talked about the LDL. Below 70, never proven to prevent heart attack. And again, our current guidelines are shifting away from numbers, like I just said. So who should take a statin? Anyone with CV disease, angina, previous heart attack, stroke, or a related condition. So we've already talked about this throughout some of our lectures. So post-acute coronary syndrome, most heart failure patients should be on something as well. Post-stroke, we haven't talked about post-stroke care or stroke care yet. We'll talk about that in the neuromodule coming up in the next month or so. But that's another patient population that would take a statin. Anyone with an LDL over 190, it's generally agreed upon that they should be on a statin therapy regardless of what else is going on in their life. And anyone with diabetes aged 40 to 75, regardless of their LDL. So if their LDL is okay, you probably still put them on a statin. Now, if their LDL is really low, like if they're diabetic and they've got an LDL of 64, maybe you don't need that. But it could be just a matter of trying to figure out where that balance is of getting LDL lowering therapy or just maybe low dose statin for the benefit of just being on a statin for the diabetic patient. It has been shown that statin therapy is beneficial for those patients in that age group. And then anyone with a greater than 7.5% chance of having a heart attack or stroke or developing CV disease in the next 10 years. And lipid lowering via statins reduces relative CV risk 20 to 30%. So if you think about relative risk, what you're looking at is a patient who might start out with a really high risk. Let's say you do your calculator here and you calculate like a 25% risk or something really high. That relative risk of 20 to 30% is going to be really impactful for that patient. Now, if it's a relatively healthy person and they calculate like 2% or 1%, they're still going to get a reduction in risk, but it's just 20 to 30% relative risk for 1 to 2% is going to be a lot less impactful and a lot less beneficial for that patient versus the person who's really high risk. So that's where that cutoff was kind of drawn and why they decided at 7.5% chance. Some people will say to go up to 10% too, and that 7.5 to 10% is sort of the middle ground where you can have a conversation with the patient. But overall, it seems like the 7.5% chance is the cutoff that was decided that, well, this is where that relative risk benefit actually kind of flips over and makes sense to put people on a statin. And mostly we're talking about primary prevention here, right? So again, this would be like secondary prevention. Somebody's already had a significant event and we're trying to prevent one from reoccurring. And then these would be more primary prevention. Diabetes is sort of outside the scope of this too. If we're just talking about, of course it's important, it's a risk factor, but this would be like, think about your average patient coming in. Maybe they have slightly high blood pressure, maybe they smoke, maybe they have slightly elevated lipids, but otherwise they're pretty healthy, they don't really have anything else going on, they aren't diabetic, they don't qualify for antihypertensive treatment, maybe they're a little bit overweight. You could use your imagination. We'll look at those scores here in a little bit. So here's the risk calculator that most people have access to, whether it's on some kind of an app you have or you use the website. It doesn't really matter. They're all the same. They should all look at the same type of information. I think if you're especially working on primary care, you're going to be using something like this a lot. A lot of them might be built into electronic medical records too as part of your visit. It probably already has all that included. It automatically will pull it in once the lab values are done. So we have some nice smart tools that can help us with our jobs from that perspective. But what I would say is just, if you're interested, play around with some of this stuff. So these are the factors it looks at. So age, gender, race, total cholesterol. 150 is kind of low. Let's put them a bit. I don't know. total cholesterol, let's say 180, HDL. So basically what I'm putting in here is a fairly healthy 65-year-old male, non-African American. He's got a total cholesterol that's considered normal. His HDL cholesterol is a nice number. Normal blood pressure. He's not being treated for blood pressure. He's not being treated for diabetes, and he's a non-smoker. So let's calculate his risk. So he comes back with a 10.6% chance of heart disease or stroke on the basis of his age, mostly. So again, we don't really have any outlying lab values. This would be a pretty healthy guy. If a 65-year-old male came in with all these numbers, on the surface level, it looks pretty good, but you have this decently high score. And there's not really anything you could do from a dietary perspective to lower the risk, because let's go back and even say, let's play with his cholesterol a little bit. Let's say he's, I don't know, let's put it at the lowest. I think this would be really low if he was 130 to see what it calculates at. So even if you put his total cholesterol at a really low value, and again, it's total cholesterol, not LDL. Remember, total cholesterol is a measurement, and we get our LDL off of that. So like the lab will calculate LDL off of total cholesterol, triglycerides, and HDL. So it's an equation it uses to figure out what the actual LDL is. So that's why TC tends to be the one they use, which is kind of a debatable thing whether that should be the marker they're using. But I think they're using that sort of, the idea is that if your total cholesterol is elevated, your LDL probably is elevated as well. It's probably what's elevating it, but not in all cases. I mean, you could have a really high HDL potentially that's dragging that up too. So yeah, who knows? But that's why they take that into consideration as well. So hopefully it matches out. So the idea is if you have, like, let's see, if I go and put some really high HDL number in here, like 100, what does it do? So interestingly enough, if I minimize his cholesterol and maximize his HDL, I mean, these are really weird numbers. You probably wouldn't see this in real life. Let's do some more realistic. Let's do maybe a more, I don't know, maybe in some really healthy people I've seen like in the 70s before, maybe in the 80s. And let's put his total cholesterol at a little bit higher, like at 160 or something. Let's see what we get there. 8.1. So anyway, you even put some realistic numbers in. It's like, if his TC was 160 and HDL is 70, you're probably not going to say, hey, I think you need to exercise to get your cholesterol down. It doesn't really make any sense. So the point here is that at his age, he's getting to the point where he needs to consider whether or not he wants to take something preventative, because at that point in time, regardless of where your lab values look like, you still have that inherent risk, and statins can lower that regardless of what the lab values look like. So that's where you have the conversation with the person on, hey, look, everything looks good here, but maybe consider a moderate dose statin to start with and see if you tolerate it. And if you do, great. It might lower your overall risk of heart attack and stroke in the next, couple decades at the end of your life. And I think it's just, again, a conversation to have with the patient. The guidelines would say to recommend treating this person. But some of the more recent opinions that have come out have said that if you're in between 7.5 and 10%, you should probably have a conversation with the person versus just saying, oh, you're at 8.1%, let's start you right away. And this person, you could say, well, the guidelines would say to consider starting. What do you think about that? If he was at 10%, like let's say his HDL was really low, like let's say 40, let's see what that gives us, 11.1%, you might want to consider, should we, I think at that point you're probably saying, yeah, you've got HDL's a little bit lower, because of this total number, your LDL is probably going to calculate relatively high, so let's get you on a statin therapy immediately. All right, so after talking about that, just to refer back to the slide, if you think about things like the patient examples like we were just talking about, you have experts arguing millions of healthy people will be put on statins for no real reason. But even if you favor that looser cutoff of 10%, still there could be some debate about how beneficial is the statin for people. Lifestyle modifications. So let's talk about lifestyle stuff really quickly. So some of the studied items out there, weight reduction for obese patients, aerobic exercise, and a low saturated fat diet are kind of the three big ones people have looked at. Weight reduction via diet alone looks like you can lower LDL by about 5 to 7% per 1.8% body reduction. I know those are really weird numbers, but that's one of the bigger studies came out with, is they're what they found that correlated best to LDL reduction. They showed that some people who had maybe really poor diet and dietary habits to begin with could get a really big reduction, so up to a 30% reduction. So you can reduce LDL substantially in some cases via just weight reduction via diet alone. Long-term compliance with any of these things, including weight reduction, exercise, are always quite challenging. Most studies will show that having a dietitian involved is going to be a more successful approach than just going with the clinician's advice. So if you do want your patient to go down the diet route, or if your patient could use a statin therapy, you believe it would be in their best interest to take a statin, recommend, but they maybe are resistant and they want to try diet first, maybe recommend working with a dietitian versus giving them advice on their own. A lot of people, diets can be tricky because a lot of people think that they know what's best, so they can go on the internet and read about various odd diets or things that they should take, or superfoods, or whatever thing they want to read about online that may or may not be scientifically sound. So that's why I always recommend bringing the dietitian in who can help weed through some of that stuff. I always think dietitians have one of the hardest jobs out there because of how much misinformation there is about nutrition and how many opinions there are about it that just don't really have a lot of science behind them. So I think having that dietitian say, well, that's okay, but let me talk about where the evidence shows and, what we talk about when we really think, we're looking at it, planning a diet that'll make sense for you. So they can really help with that and help people, again, kind of cut through the junk that's out there online. There was a study that looked at 12,866 high-risk men, and they showed reductions in LDL from various lifestyle modifications, including these things. So it looked at an incorporation of all these, and they didn't significantly reduce CHD or all-cause mortality. So the interesting with these men is they all underwent lifestyle modifications. They all dropped their LDLs by somewhat of a statistically significant amount, I should say. But they didn't actually show any mortality reduction with that. And then the one thing, caveat, LDL reductions were pretty modest. So like the people who were in the non-lifestyle group, their LDL reductions their LDL wasn't substantially different. I mean, it was statistically significantly different. I mean, there was a drop, but the question some critics have had is that, is a difference in LDL enough? What is the magic number, and how big of a difference do you have to see that CHD or all-cause mortality reduction? We don't really know what that is, and that's a big area of controversy. As you can see, or if you do some research on your own, there isn't a ton of evidence for diet and cholesterol reduction, and diet and all-cause mortality reduction to begin with. And that's not saying that you can't get impact from diet. In fact, a lot of first-line recommendations are lifestyle modifications, but we simply don't have a good pool of evidence that says exactly what we want people to do. So it's like we kind of know that these things will lower LDL, but we are lacking the data to say how big of a decrease in LDL do we need to make that impact, and what's the best way to do that via modification of lifestyle. And again, we're kind of at the mercy of anecdotal evidence or having a patient try what they think they're going to be comfortable with. At the end of the day, medications and lifestyle is probably the best way to approach it, but I'll leave that up to you in your practice. Okay, so let's talk about statins again. Statins are HMG-CoA reductase inhibitors. They inhibit the rate-limiting step in cholesterol biosynthesis. They're a cornerstone of high cholesterol treatment, probably one of the most extensively studied classes of drugs to ever hit the market, the world market, used for both primary and secondary prevention. The mechanism is not super well understood. Yes, we know they lower LDL by decreasing cholesterol synthesis. However, they also see some other things, interesting side points here. So regression of atherosclerosis rarely occurs. So benefits are seen in as little as 6 months, and 6 months is not long enough for significant regression. So the idea is that if you're measuring the plaque buildup in somebody's artery and you look at it after statin therapy within 6 months, you don't really see any change in there. But yet within 6 months, those patients already have a lower risk of having some kind of an event. So it's interesting that they aren't really changing the size of the plaque per se, but what you're seeing is a more stable plaque, so the plaque stabilization is an interesting component of statin therapy. We don't really understand exactly why that happens. Other factors to consider, so reversal of endothelial dysfunction, decreased thrombogenicity as well. Some other interesting things that statins seem to manipulate. This is just a diagram to show you a little bit more about the mechanism of action. You've got HMG-CoA here, and so HMG-CoA reductase converts HMG-CoA to mevalonate, and statins inhibit that step, and ultimately you can see that that gets made into cholesterol. And so, and this is kind of the rate-limiting step, and if you don't have this component, you don't have cholesterol synthesis, or you're limiting some of your cholesterol synthesis. You can't really shut it all down, but you can shut down some of it. So they're the most potent LDL lowering drugs we have available to us. They have varying potency and side effects, and usually diminishing returns. So that first dose of statin is usually going to give you the biggest bang for your buck, and then the higher doses you go, you don't get quite a doubling effect. And I'll show you a chart here in a second that illustrates that. Modest HDL increases. HDL increase with statins is pretty small, but simvastatin, for example, seems to have a bit higher than some other ones. The best LDL lowering statins are rosuvastatin and atorvastatin. So when you hear about high potency or high intensity statins, we're talking about these two drugs and none of the other ones. Brand name only is pitavastatin. It's kind of an odder statin that's not used very often. Rosuvastatin or Crestor was brand name only for a while, and it just went generic in the last couple of years, or maybe last year. So that's become a lot less expensive. I don't care you know these studies. These are just some examples of the different studies out there and the numbers needed to treat to reduce coronary events. It's pretty good evidence, and my point here is just that there's a lot of studies like this out there. These are some of the older ones and some of the more interesting ones, but at the end of the day, they didn't even look at any of the high potency statins in these ones, and they're finding good evidence for statistically significant, relatively low numbers needed to treat to reduce a coronary event. So statins do have a huge pool of evidence that support their use. It doesn't mean everyone needs to take one, but it does mean that they're a good tool in our arsenal. Some other interesting trials. I think the Jupiter trial to me is one of my favorite ones that highlights just the uniqueness of statins as a drug and why they have some kind of interesting mechanisms of action that we don't fully understand. So the Jupiter trial looked at using rosuvastatin, and it didn't target LDLs with people. Actually, I think everyone in the trial had to have an LDL below 130 to be included, is what their cutoff was. And they targeted people with, I think, an LDL below 130 and a C-reactive protein of greater than 2.0. If you haven't talked about C-reactive protein, it's just sort of a general biomarker of inflammation. They use it a lot more in peds than they do in adult medicine for things like sepsis and things like that. But anyway, they looked at C-reactive protein in this trial. And they showed that rosuvastatin versus placebo reduced C-reactive protein and showed a significant cardiovascular event reduction and reduced all-cause mortality. So the idea here is that it probably reduced their LDL too, but their LDL wasn't substantially elevated to begin with. So we have an LDL reduction, we have a C-reactive protein reduction, and we have a study focusing just on the C-reactive protein reduction, showing an all-cause mortality reduction and a cardiovascular event reduction. They're both their primary endpoints, showing statistical significance. And this is kind of a landmark trial that really showed us and kind of opened people's eyes to say, well, statins don't really work like we thought originally. And a lot of the theories behind statins were kind of given maybe more validity from this particular trial. And because of this, we expanded a lot of our primary prevention indications to say that, and this was one of the trials that led us down the road of maybe numbers aren't the most important thing to look at. Maybe we need to look at overall risk and just using these drugs in people who we think might have high risk because of any given factor, not necessarily just because of their cholesterol. The Prove It trial was another interesting one. High-dose atorvastatin post-ACS compared with standard pravastatin showed a 16% reduction in death or major CV events. This was one of the trials that put high-dose statin therapy on the map as a primary goal for people post-ACS. So previous to this trial, we were just treating people with statins in general post-ACS. It's not like this changed that. What it did change was that we start a dose high and we target a max dose. So max dose statins are either atorvastatin 80 milligrams or rosuvastatin 40. And either one of those, they're fairly equivalent. And again, I'll show you a chart to compare those two. But that's considered to be the goal for a post-ACS. So that's kind of an interesting change in therapy where we didn't used to do that. And of course, there's some issues with side effects potentially there, which we'll talk about in a little bit. This chart shows you the differences in statins in comparison. I don't really care that you know much of this. They're all taken once daily. One of the things you'll notice that their half-life does vary quite a bit. So like pravastatin, simvastatin, fluvastatin, they all have really short half-lives. Lovastatin. The reason behind their potency being lower is likely because of this half-life shortage. Now, why don't we take them multiple times a day? Well, they were never really studied that way, so I don't know. It's a good question. But the point is that you can still get really good, or somewhat decent, I shouldn't say really good, somewhat decent LDL lowering with those drugs, even though they aren't super potent. The other thing to think about, if you're giving somebody anything other than atorvastatin, pitavastatin, and rosuvastatin, any of these short half-life products, you really want to give them at night before bedtime. Your body synthesizes cholesterol while you sleep. That's the highest time. So to maximize that statin, usually you take it at bedtime. A lot of people will say to take the longer-acting statins around the evening meal or bedtime so that they're hitting their peak kind of overnight as well. It makes sense. So a lot of times you'll hear people to recommend taking statins either in the evening or at bedtime. If your patient is like, I can't remember that, I take all my meds in the morning, I'm going to take my rosuvastatin in the morning, that's fine. Don't fight them on it, but ideally you take it in the evening. That's probably the best practice. Some of the other stuff on here I'm not super concerned about. We'll talk about the solubility here in a second. So notice that they're all lipophilic except for pravastatin and rosuvastatin are hydrophilic. So the lipophilic drugs might get into the central nervous system more, and there's some concern about central nervous system effects in statins. So we'll talk about that here in a second. Renal elimination is minimal. You don't have to renally dose adjust statins, which is a nice aspect of their therapy. Food absorption doesn't really matter. Active metabolites doesn't really matter. And again, so a lot of this stuff, optimal time of administration says anytime, but again, a lot of people will say take them in the evening. And I think, again, if they're a short acting, you still want in the evening is when I would probably recommend taking the drug. Okay. Here's the different brand names if you're curious and want to know, just for reference on what the brand names are of the different statins. This is just a joke I put on here. Well, this isn't a joke. This was a real advertisement from a Novartis that they did in Italy, where it got a lot of controversy because they're showing a couple of people just eating a lot of looks like high-calorie food, and then it's advertising a lower cholesterol drug. So it's kind of that notion of, oh, you can eat whatever you want, just take your statin with it and you'll be fine. And that's been that's just, of course, for a lot of reasons, not a good idea. Statins aren't a supplement for a bad diet, right? So just that kind of mentality was originally used in some marketing schemes from some of these companies. Comparison of, so this is a comparison chart that I was alluding to earlier, where we have the different drugs and the different potencies with dosing. So how much LDL lowering you get. You can see Crestor is way up here, rosuvastatin giving you the most bang for your buck. Even the low dose 5 milligram rosuvastatin is higher than basically anything else we have. So even it's even equivalent to like a fairly mid dose of atorvastatin, which is pretty impressive. So a lot of times you'll see people, if they're going to be on a low dose statin therapy, like maybe they're having issues with tolerability, low-dose Crestor is going to give you much more bang for your buck than switching to one of the lower potency statins like pravastatin or fluvastatin. And then we have atorvastatin giving you at 80 milligrams here. Not quite the same as 40 milligrams of rosuvastatin, but similar. So again, these are our two high potency, high dose options. So when you hear high intensity statin therapy, this is what we're targeting here, either that 40 of Crestor or that 80 of atorvastatin. Statins have a pretty good safety profile, despite some of the flack they get, I think. They're probably the most widely prescribed drugs in the world. So when you think about safety profile, you have a ton of different pools and populations and large groups of people taking these medications, so you're going to see side effects. At first, hepatic dysfunction was thought to be a big deal with them, but actually some of the more recent evidence shows that hepatic dysfunction is quite rare, and actually their severe liver injury is so rare the incidence is no greater than with the general population. So whether you're on a statin or not, you have the same incidence of having a severe liver injury. The biggest risk for some transient liver damage is in the first 3 months of therapy. It's usually dose dependent, so those patients on those high doses, high potency statins, probably higher risk. Monitoring, usually people will get baseline labs, although I think this is even going out of favor, but it's probably not a bad idea to get a baseline liver panel just to make sure you've got that on file. And then we used to recheck regularly, but now you only recheck if clinically indicated. So if your patient comes in and looks kind of like this, where they've got jaundiced eyes, it's probably a good sign to check them. Or if their INR is elevated for no reason, good time to check a panel. Or if they're bleeding or something, of course. Those would be things to look at. Usually we're looking at ALT elevation, which is going to be about 3 times the upper limit of normal on 2 occasions. And if that's the case, you want to decrease the dose and see if that helps, or change the medication altogether. Statins are category X in pregnancy. That's where if you have a woman of childbearing age who could benefit from statin therapy, where you might have to have a conversation of what the best approach would be for them. Memory loss is something that's been looked at with statins. Some people think there's a link between statins and Alzheimer's disease. I'm not exactly sure where this came up. It's been studied here and there. There haven't been really a great correlation between the two. But people do say that if you have the general theory is if you have a younger patient, the idea is to give them something that isn't as lipophilic. So remember, our lipophilic drugs here would be more likely to cross the central nervous system, whereas pravastatin or rosuvastatin, hydrophilic, less likely to get into the central nervous system. You don't need the drug in the central nervous system to make it work, right? It's working in the liver. So considering prava or rosuvastatin would probably be preferable in a younger patient if you're concerned, like especially if they had a family history of early onset Alzheimer's or something like that. Diabetes, there seems to be an association with statin therapy and prevalence of diabetes, and we aren't exactly sure why. If it's a mechanism related to the drug or related to the patient population, we don't really know, but there does seem to be a correlation there. Whether there's a causation is not, we don't understand this well enough to make that assumption yet. Statin myalgia, biggest concern and most common complaint is a 2 to 11% incidence. First, rule out other causes. Make sure your patient didn't just like run a marathon or something like that, or didn't do something strenuous to cause this. Lab value you're going to see is evaluated creatinine kinase. Pravastatin and fluvastatin are thought to have the lowest risk, sometimes thought to be dose-related. Drug interactions, most statins are CYP metabolized, and pravastatin has the least potential for drug-drug interactions. Simvastatin has several dose restrictions, and it's CYP3A4 metabolized, so it interferes or competes with a lot of things. So there's a lot of restrictions for giving simvastatin with other medications. For example, simvastatin and amlodipine, you can't give more than like 20 of simvastatin with amlodipine because they both compete for the same enzymes, and it's been shown that if you have a drug on board that's competing for metabolism with simvastatin levels increase substantially and myalgia risk goes way up. So the idea here is if you have myalgia incidence, you're going to want to try and decrease the dose of the statin or try a lower potency statin overall if that doesn't work. Ultimately, rhabdomyolysis or total large muscle breakdown is quite rare with statins. It's possible, and it can lead to things like renal failure. So we do want to take it seriously and educate our patients, but this is by far the most common side effect people are going to report, and intolerability to statins people will report. Occasionally you'll see people on, sometimes like I've seen, like a once weekly statin where they're taking like 2.5 milligrams of Crestor on Mondays and that's it. And that's because they've had some intolerances to various statins, and it's like, you should be on a statin for whatever reason. They really need it based on evidence. So let's get them some statin in their body, whether it's once a week or every other day. So you might see creative dosing like that. There's no real evidence behind it or guidelines to recommend that. But some providers will say, well, it's got to be better than no statin at all, so we'll try it. And if you can get them on some kind of a low-dose regimen, it's probably better than nothing. So again, remember that first dose is that first starting statin point is usually your biggest bang for your buck with LDL reduction, and you should hopefully get some benefit from that, even if the patient's on almost what most people would consider to be a subtherapeutic dose. Managing statin-induced myopathy. So again, hold your statin, check your drug interactions, correct hypothyroidism. That can have an effect on it too. Vitamin D deficiency is thought to have been linked as well, so correct that if the patient is deficient. Coenzyme Q10 has a role in muscle cell energy production. Statins may decrease coenzyme Q10, however, which is something our bodies use naturally. It's a thought that if we supplemented it, it would help, but actually there's no evidence that it does anything. For some reason, supplementing coenzyme Q10 doesn't seem to have the same effect as the way we get it or synthesize it endogenously. Anyway, the supplementing CoQ10, a patient can do it. It's probably not going to hurt them at all, but it's not likely to provide any overall benefit. Deciding who needs a statin, use your calculator. Remember that guidelines are guidelines, not absolute law. Some patients may be resistant. You can approach a healthy lifestyle via diet and exercise, but it just does not have, currently we don't have the proven benefits of the statin though with that. So which statin? Simvastatin, atorvastatin, and rosuvastatin have the best evidence for preventing heart attack and stroke overall. So I'd say rosuvastatin and atorvastatin being high potency. If you can get your patient one of those are going to be the two preferred. And they're all generic now, so there's no real cost difference, or shouldn't be a huge cost difference between any of them. Genetic testing may help refine which statin would work best. Until we get there, our guidelines are our best option. So we'll see if genetic testing to metabolic pathways and things like that come out in the future, but currently not available for statins. I read articles like this every once in a while, or family members or friends send them to me, and they're like, oh, I read about, statins are not that helpful and more people take them than should be. And it really comes back to that whole controversy about with the risk calculator, and just the problem is that as you get older, you're at higher risk for a heart attack and a stroke. And even those older patients who are at higher risk, regardless of their labs, it's shown that statins benefit them and decrease their risk. So at the end of the day, is it going to give you the biggest bang for your buck to treat that? Like if you look at that patient we were mocking up earlier, that 65-year-old who's mostly healthy, is that going to be as beneficial as treating the 55-year-old who just had a heart attack? No, probably not. But it doesn't mean we shouldn't do it. It doesn't mean we shouldn't have the conversation. So anyway, go with what the evidence tells you. Go with what the risk scores tell you. And remember that sometimes age alone is enough to be a risk factor, and it is still worth having that conversation with the patient about starting a statin, just so they can hopefully maybe avoid that serious complication, stroke, heart attack, whatever it may be in the future. Certainly worth a conversation. You don't have to force the statin on the person, but as a medical professional, I think it's our job to make sure we're providing the best recommendations with the evidence we have available to us. Okay, we're going to talk very quickly about a lot of these other drugs. The bottom line is none of them are really recommended anymore. They don't really have a positive, we'll get to them maybe in familial hypercholesterolemia, but at the end of the day, it's kind of like statin or nothing, maybe with the PCSK9 inhibitors fitting in here somewhere. Fibrates, the real advantage to these is that they can lower triglycerides, and if your trigs are really high, it's hard to measure LDL because of the way that LDL is calculated. It's calculated from total cholesterol, triglycerides, and HDL. And if your triglycerides are really high, it makes your equation impossible. It makes it like a negative number at that point, which isn't possible to have. So the point is that if your trigs are really high, you need to get them down to even know what your LDL is to begin with. And if your trigs are really high, it's probably a sign of some sort of metabolic disease as well, whether it be uncontrolled diabetes or a complication of obesity or something like that, and probably worth bringing them down to begin with. There's not a lot of mortality data. There is maybe a risk reduction in CV events with high triglycerides and low HDL if you can reverse some of those things, but we don't really have a great pool of evidence compared to LDL. The mechanism with fibrates, they activate proliferator activated receptor alpha, or PPAR alpha, which is results in lipolysis and elimination of triglyceride-rich particles from plasma. So it kind of works as your body's endogenous mechanism to get rid of extra triglycerides. And they also increase HDL synthesis, so you get a little bit of an HDL bump as well. Gemfibrozole and fenofibrate are the two drugs in this class. Fenofibrate's a bit better tolerated. They essentially are interchangeable, though. I think fenofibrate was the newer medication. It was brand name for a while. It's been generic for several years, though, so they're both fairly affordable. I think fenofibrate overall is the more tolerable option. Gemfibrozol also has some drug-to-drug interactions and can interfere with liver pathways and things like that, contraindicated with severe renal dysfunction. And fenofibrate has less risk of overall muscle toxicity, and some other things like that. So if you do have muscle toxicity, myalgia, if you do have liver dysfunction, giving these drugs in combination with a statin can really exacerbate that. So you got to be careful with the combination therapy, but for the most part, they can be safely given together for the average patient. You just got to watch some of the side effect profiles and maybe do some extra monitoring on the liver panel side and make sure the patients are aware of the extra myalgia risk. Niacin is also vitamin B3. It was basically the lipid-lowering agent preferred before statins existed, and it's the drug that's the best at also raising HDL. Mechanism decreases hepatic production of VLDLs. Remember we talked about those. Inhibits free fatty acid release from adipose, maintains structure and function of HDL. There's a bunch of different products on the market. Some of them are over the counter, so you can obviously buy vitamin B3 from in a Nature Made bottle or something like that. There's also something called slow niacin, which is a slow release niacin product. Niacin causes flushing when you take it, especially in an immediate release form. And so if you take the extended release, it can help with that. There's also Niaspan, which is a pharmaceutical product. Highly recommend if you're going to prescribe niacin, you prescribe the Niaspan version. Niaspan's been generic for a while too. It's just a pharmaceutical grade product. I'm going to talk about supplements in I think a few lectures here. I'm skeptical of the supplement industry. I'll just say that out loud. The reason is, very quickly, there's no FDA regulation on what somebody puts in their bottle. So somebody might have a vitamin B3 product, and it might say there's 100 milligrams in there or whatever, and there's actually nothing in there. There could be nothing because there's no regulation behind it. So I highly recommend if you're going to prescribe something, try and get the best product possible, which is going to be a pharmaceutical grade product that's undergone FDA testing and has proven quality assurance behind it. Other side effects: hyperglycemia, hyperuricemia, rare hepatotoxicity, contraindicated with high-dose statins, and myalgia. We don't really use niacin therapeutically all that often anymore. There isn't a lot of evidence that using niacin to increase your HDL provides really any mortality benefits. So from that perspective, it's fallen out of favor. And at the end of the day, it doesn't really have the same robust set of data or even close to it to support its use compared to for lipid lowering compared to something like a statin. It's just there isn't really a great place in therapy. I think if you were having some difficulty with statins and the person maybe wasn't tolerating a high dose statin, maybe they have to be on, maybe they're that person on that, really low dose of Crestor once a day, 2.5 milligrams or something like that, and you really want some extra lipid lowering, or their HDL is just abysmally low, maybe you want to give it a shot. I'm not going to say you're wrong, and it might be worth a try, especially if they tolerate it. It's pretty benign overall. The side effects are quite rare, and as long as you aren't combining them with a really high dose statin, you're probably in the clear for the most part as far as myalgia risk. But at the end of the day, you want to make sure that you're taking those things into consideration. And niacin has maybe some roles here and there, but it's not a super popular drug anymore, just for those reasons. Bile acid resin sequestrants. They're not systemically absorbed. They just work in the small intestine to block resorption of bile acids, so it downregulates your enterohepatic recirculation and downregulates LDL receptors. It's a very uncommon therapy. It's inferior compared to basically everything else, 2 to 4 times per day dosing, malabsorption of various vitamins. It is okay to use in pregnancy, so if you have that pregnant person who can't take a statin but you want to try and keep their cholesterol in check, this might be an option for them. And I listed the products here, but it's a very unusual drug to see regularly. Ezetimibe, or Zetia, is a cholesterol absorption inhibitor, blocks uptake of cholesterol in the small intestine, marketed for use in combination with the statin originally. Its original market was a drug called Vytorin, which was a combination between simvastatin and ezetimibe. However, the outcome trial didn't show that it was better than simvastatin alone initially with the ENHANCE trial, and then the IMPROVE IT trial came out and said, actually, we do see some mortality benefits when we add ezetimibe. So the funny thing was with the ENHANCE trial is they did all this study that said that it does lower your LDL further to add the ezetimibe on to simvastatin. However, you don't get any mortality benefits with that LDL lowering, and it kind of led to the whole background factor that it's statin or bust, right? You have to have the statin on board, and the LDL doesn't really matter. Now, some newer evidence is saying, well, actually, we looked at some evidence, and we looked at a more long-term trial and showed that, yeah, you do get some mortality benefits with the Zetia on board versus just the statin alone. Now, it's just simvastatin, though, so the question is, what about rosuvastatin? What about high-dose rosuvastatin? What about high-dose atorvastatin? Does it make a difference? So there's some questionable study design there, but at the end of the day, it does provide additional lipid lowering, and it is an option for somebody, for that person who you've got on a statin, you've got on a good dose of a statin, and they're still above 190. Maybe this is a one worth trying. It is generic. It's been around for a while. I said it's not generic. It's gone generic now. It's just old. It's more recently generic. So it's not really an expensive option anymore, although it's a rare option. So it's probably not made by a lot of companies. So I'm guessing it's not super cheap. But the benefits, I should say, not necessarily minimal, because I can't really back up that claim, but I'll say questionable benefits. That's a better way to describe that. Expensive, and I'll put a little question mark here with questionale. There you go. Questionable benefits. There you go. So at the end of the day, ezetimibe does have some place, but we'll talk about that in a little bit here. All right. So you guys did some research on PCSK9 inhibitors for your forum post last time around, and had some interesting things I read about, and it seems like a lot of you guys dug into this well. So hopefully you guys got some of this already, but I'll cover them really briefly. I'm not going to spend a ton of time on them because they're not going to be drugs you commonly prescribe at this point in your career. And if you are thinking about them, you probably want to get a second opinion. They're expensive, and not to say you guys don't have the the know-how to prescribe them, but I'm just saying that if it were me and I was thinking about putting somebody on this, I would ask a colleague and be like, what do you think about this? Is this the best option to go with? All right, so proprotein convertase subtilisin kexin 9 is what PCSK9 stands for. It's a liver enzyme that leads to LDL receptor degradation. And so if you go back to our original slide about mechanisms, that should make sense as how the receptors upregulate and things like that. It's working differently than a statin. Monoclonal antibodies, so they are MAB drugs. They are biologic agents, which means they will always be fairly expensive. Allocerumab is Proluent, and evolocumab is Repatha. They're sub-Q injections for either every 2 weeks or every month, depending on which drug it is, respectively. Potent LDL reduction up to 70% is monotherapy, up to 60% is statin adjuncts. So again, this is on top of a statin or just by themselves. They pretty much obliterate your LDL. Potential areas for use: familial hypercholesterolemia, I'll show you that here. Statin intolerant patients and really high risk patients. This is the question mark. Like, if we have those high risk patients, let's look at our post ACS pool. Is it more beneficial to start them on a PCSK9 inhibitor right away versus a statin, or do you combine and give statin and PCSK9 inhibitor right away? It's really aggressive already with our statin dosing, using high potency, high dose statins. Do we want to take that a step further? Those are questions we don't have answers to yet. Bottom line evidence: largest meta-analysis showed a decrease in all-cause mortality without increases in adverse effects, regardless of indication or concurrent statin use. Pretty decent evidence with these. On a statin already, CV event reduction from 2.18% to 0.95% over 1 year using Repatha. A lot of times you see this as a relative risk reduction of 30%. You have to remember that the reduction is absolute. If you look at the absolute reduction, maybe not quite as impressive. It's a couple percent reduction. So the number needed to treat is quite high to put people on PCSK9 inhibitors to get that benefit. And again, they're really expensive. And similar here with this trial too with Proluent. All right. Cost, again, widespread use would be a huge, think about how many people are on statins and how many people potentially could benefit from lipid lowering effects. Lots. So we really need to hone in on where these drugs are most appropriate. Statin intolerance in trials can be misleading, and some of the criteria for statin intolerance was questionable as to why the patient was statin. Do they try other statins and other things like that? There are lots of questions there for how they pick those patients. Lowering LDL alone has a mixed group of evidence. So again, we go back to our original theory that statins have this benefit besides their LDL lowering effects. So do these drugs really have enough long-term data to support that they have those added benefits besides just lowering LDL? At this point, they just haven't been on the market very long, and they don't have that robust set of continued long-term evidence that statins have. So they really have a disadvantage when it comes to that, comparing them side to side against statins. Side effects to watch out. There is a big concern with these at first, which I think has mostly been debunked, of a neurocognitive deficit. The theory behind this is that because PCSK9 inhibitors can lower LDL very substantially. I mean, sometimes you get people in like the 20s and 30s with PCSK9 inhibitors, which if you take a really healthy adult, having an LDL below 70 is kind of rare, and below 60 would be really odd. So your body needs some LDL to do things. And if you don't have any, the question is, are you able to replicate cells or rebuild cells correctly? Can you synthesize hormones properly? Are you able to use cholesterol to its fullest advantage? Are you inhibiting some bodily processes? That was a big concern, still is, but initially there was some neurocognitive deficits seen in small amounts, but significant amounts in some of the trials, but actually they haven't really shown replication of that, and some of the evidence is questionable to begin with. So from what I know, it's not a huge concern like it was when they first came out, but it's still something they're watching for long-term studies. Some interesting side effects. Upper respiratory infections like and influenza are higher, so somehow it's manipulating the immune system, which I thought was kind of interesting. Injection site reaction, which we're going to see with any MAB being relatively high. Again, that's the biggest side effect of a biologic agent, is some sort of a hypersensitivity. And then again, you've got things like UTIs and bronchitis, stuff like that. So think about infectious with PCSK9. It's kind of an odd set of side effects. Why? I don't know. I don't have a good answer for that. Primary versus secondary prevention. So now we're off of PCSK9, just talking about general primary and secondary prevention. So primary, diet and lifestyle, take all factors in considerations. Look at your goal, quote unquote, LDL. Basically it's below 190 at this point. If they don't tolerate, if you're looking at primary prevention and they don't tolerate a statin, there's not any good evidence that says, even if their LDL is elevated, there's no evidence that says put them on niacin or put them on bile acid sequestrin or Zetia. There's just not evidence to support that, so we don't recommend that. Usually for people intolerant to statins, you just focus on lifestyle if they can't take it, if it's primary prevention. Again, these people haven't had an event yet. Checks LDL about 6 weeks after starting statin therapy, and then usually every 6 to 12 months thereafter. That's where you see your effects. Secondary, similar to primary, but pretty much we're just giving statins regardless of their LDL. So that's the difference there. Here's some algorithms. This would be more of a primary. It would be a primary prevention algorithm in patients who have no previous cardiovascular disease. So we're going to look at their LDL, measure it. Is it above 190? We're going to evaluate them for familial hypercholesterolemia. If that's absent, we're going to start high intensity statin therapy right away. If not, I'm going to show you the familial algorithm here in a second. If it's not elevated above 190, we're going to look at calculating the 10-year risk. So if it's above 190, we don't even care what their 10-year risk is. It's kind of funny, right? And you can still calculate it and tell them, but you're going to start them on a statin regardless. So anyway, we calculate their 10-year risk. If it's greater than 10%, moderate dose statin. Repeat your LDL in 6 weeks. And if that LDL has fallen by 35 to 50%, continue that statin. Or you could consider increase to high dose statin if the risk is greater than 20% and the LDL is still greater than 100. If it isn't falling, look at patient compliance. That's really all there is. If the patient's compliant with it and it's not falling, I don't know what to tell you. It could be maybe they're elderly or who knows, and resistant to statin therapy for some reason. Discuss statin with, and by saying elderly, I mean that they're still going to calculate pretty high. So this could be a patient who is older, calculating above 10%, but maybe their LDL is like 130. It might be difficult for them to get it lower than that. You might just not see a huge reduction with statins. Some patients are just low to begin with, but will calculate with a high risk, right? It goes back to our original conversation at the beginning of the lecture. So we want to discuss for 7 to 10%. This is, again, your discussion point. The guidelines would say to start somebody, but up to date would recommend having a discussion. I think that's fair. And then under 7.5%, follow recommendation for repeated screening. At that point, it's like, your cholesterol's not high enough for us to treat. If the patient was like, my cholesterol's 180 and younger, but I'd prefer to be on a statin, I don't think you'd be without I don't think you would have an issue prescribing that if they wanted to try starting a low-dose statin and see maybe with some dietary modifications, things like that. I don't think that's wrong. So there are patients who actually might be the opposite of the person who's resistant and actually says, I really want to be on a statin. I've heard they're really good. But you could say, well, your risk just really isn't that high right now. So maybe the benefits don't outweigh the risks of taking the med. So again, conversations to have with your patient. I'm not going to talk a ton about familial other than this one slide. There's two types. Homozygous is very rare, and sometimes homozygous patients have extremely high LDL cholesterol. You can see it like over 500, like really, really high numbers. But this is more about heterozygous and how we treat them. There's not really a standard set of evidence or information behind homozygous patients just because it's such a rare subset. But it would be probably pretty similar. So setting an LDL goal, if you want to read more about what the goals are, usually you're looking at targeting below 130, but that just depends. Your initial lifestyle modification, consider aspirin therapy can help with these patients as well. It helps that platelet if they have a higher risk for plaque rupture, helping with decreasing the platelet aggregation response. And you want to start high-dose statin. If you can get the LDL at goal in 3 months, that's great. Continue the prescription, recheck 6 to 12 weeks, and then yearly. If not, refer to a specialist at that point. They'll evaluate the goal, change the goal. They could add ezetimibe. So this is where we actually do use ezetimibe sometimes, is in these patients with familial. LDL still not at goal, then you go to the PCSK9 inhibitor, and then you would consider like LDL apheresis, where you're basically doing plasmapheresis to remove the LDL from the body physically, which is kind of an interesting therapy in itself. So that's familial. I'm not going to test you on familial. I just wanted to throw it in there just to tell you. So from an exam perspective, I really want you to understand, like if I gave you a risk score, say somebody above 10% or somebody's LDL above 190, what type of statins are we looking at? I want you to know which two are the highest potency. And I want you to know some about the side effects, but that's pretty much it. And also be able to recognize some of the lower potency statins too. I don't think I really went through this, but I'll just mention it quickly because I think I forgot. One drug that sort of has some utility that I glossed over is pravastatin. And one of the things that's interesting about pravastatin is it has no active metabolites, and it doesn't get metabolized by the cytochrome P450 system. So if you have a patient who's really prone to drug interactions, maybe they're on transplant medications or whatever it may be that you don't want, anti-epileptic drugs, things like that, that have very specific blood concentrations you want to titrate to, these drugs can all possibly interfere with some of those really common pathways. I mean, these are all really common metabolic pathways. So pravastatin has none. It metabolizes differently. So it's a drug that can have some advantages for those patients. Rosuvastatin also actually has fairly limited profile, but it's still 2C9, which is a fairly common pathway. So again, if you want no drug interactions at all, pravastatin is your drug of choice, and that's just one I would highlight there as an important thing to remember. The other low potency ones I really don't care you know much about, other than some of the stuff I already highlighted in the lecture, like simvastatin has substantial pathways that get have interference with them and things like that. So, all right, that's it. We'll see you guys next week with diabetes. The next set of slides with the thyroid lecture, I'm just going to repost the lecture I did from last year because I didn't change anything. Thyroid hasn't really changed at all in the last 5 years. There are some diabetes review questions on there, and they won't really make sense right now, so you can feel free to skip over that part, and we can maybe go through them again at the end of the lecture next week before the exam. So anyway, thanks guys, and I'll see you next week.